Hello and welcome to Westwind, an audio podcast about cancer, technology in medicine, and policy issues. I'm host and medical oncologist Dr. Jack West from the City of Hope Comprehensive Cancer Center in the Los Angeles area. You can find Westwind material at beaconmedic1word.com, at iTunes, or just about anywhere you get podcast content. I would just ask that you show your interest and support by subscribing, commenting, sharing by telling friends and colleagues in person and on social media, and rating it however you feel is appropriate. You can also share your ideas and opinions by emailing us at westwindpodcast@gmail.com. I'm very happy to be joined today by Dr. Alfredo Addeo, who is Senior Oncology Consultant in the Oncology Department at the Geneva University Hospital in Geneva, Switzerland. He has experienced oncology care in many different healthcare systems and is really a great dynamic participant in lots of social media conversations that are part of our global oncology community. And it was through Twitter that I first encountered and interacted with him, but I'm delighted to have actually connected with him in real life at ASCO in the past, and I'm very much looking forward to participating in a lung cancer summit, an international lung cancer summit that he co-chairs that will be taking place in Geneva, and we'll talk more about that. That's a little later. But in the meantime, let me just say, Alfredo, thanks so much for taking the time to speak with me today.
You're welcome, Jack. It's a real pleasure to be here with you. I'm absolutely delighted to have the opportunity to have this chat with you today.
Excellent. So I like to start with the deep background of where people grew up and what that was like. And I believe that was in Italy for you, but can you tell me more about your childhood, where you were raised, and whether you envisioned that you would be going into medicine?
Yeah. So basically, I was born, as you can hear from my accent, I'm Italian, and I was born in the south of Italy, in Naples. But at that time, my parents had already a job in the north of Italy, in Turin. So I basically grew up in Turin, so in the north. I still have a strong link and a strong bond with the south of Italy. And we might talk about it later, but there's a difference between... In Italy, we say that there's a difference between northern people and southern people, the way they behave. And I feel kind of more close to people from the south. But anyway, I spent most of my life in the north of Italy, in Turin, where I did all my school, my medicine school, my training as an oncology. So growing up in Turin was absolutely fine, apart from some issue with football, as I was a supporter of Napoli, which is a football team, of course, from the south. And in Torino, there is a strong team. I don't know whether you follow this or not, but it's Juventus. So it was kind of hard at that time, but it was, nice childhood. And
right. They take their football, their soccer quite seriously there.
Yeah, they do, actually. And I also had a problem because my brothers support Juventus. So it was a kind of a fight in my house, but it was fun. And we still fight a little bit, but a bit less now because I've lost a bit of interest compared to when I was very young. But having said that, I decided to become a doctor very late. I remember I was at high school, and everybody knew already what they wanted to do or what they wanted to become. And until the very year of my high school, I was a bit unsure. And then my dad got sick, and then he had lung cancer. That was my first serious experience with a mortal disease, a lethal disease. And I had then the opportunity to have an uncle who was a physician. And he came over and tried to reassure us and explain things to us because I couldn't understand much at that time. And then by reading the medical book that he brought, I kind of got hooked, and I thought it was very interesting. I got fascinated, and that's how I decided to pursue a career as a doctor. Not necessarily an oncologist at that time, but a doctor at least. And then during the medical school years, I kind of made up my mind about becoming an oncologist.
What drew you to oncology in particular?
But I remember at the beginning was just curiosity, the fact that wanted to understand. We're talking about, probably 1999, something like that. At that time, I was curious to better understand biology of the cancer, how a cancer could develop, how it could metastasize. And so it was curiosity first. And second, I think it was probably a personal experience. The fact that I was invited for I could choose, like in the training is a bit different in Italy, but at that time, during your medical school, you could, if you wanted, spend 6 months or even a year in a department or a service. And at that time, because I was curious, I decided to follow for a few months oncology, and for a few months a surgical department, which was general surgery, but a bit of oncology surgery. And what kind of made me swing towards oncology was the relationship with the patient. So I had the impression that by doing oncology rather than becoming a surgeon, I could perhaps establish stronger relationship with patient and with families. And that's what it basically, I think what was very important for me was really convince me to become an oncologist. Not necessarily the fact that my dad has a lung cancer. That was just I don't want to say a coincidence, but it wasn't that the reason why I wanted to become an oncologist. It was more about the idea to have a stronger connection with patients and their families.
I might even have imagined that the direct connection with your father, and lung cancer is a notoriously challenging disease, that it might have pushed you away from oncology or even lung cancer specifically. But I'm intrigued that wasn't the case, and you remained curious and drawn toward it, despite that connection.
Yeah, frankly, what happened is it was the other way around. At that time, frankly, I remember really clearly that a lot of doctors were trying to explain to me, and it's also learned me how difficult it is for people who are not doctors and not physicians to understand even simple words. Like everybody was talking about mediastinum nodes. And if there are no mediastinum nodes, we can do surgery, blah, blah. And I couldn't work out in my mind what the hell was this mediastinum. And we're talking about an era where internet wasn't there. So it wasn't easy to find, the definition of something, or it's not like now Wikipedia. So I still very vividly remember how complicated I thought it was to understand what the hell was going on with my dad, why he couldn't have surgery, or why he could have surgery. And having those fascinating books, I remember there was all the figures with all the drawing very clearly. It's like it was a revelation. I thought, God, this is fantastic. I can understand. It's so fascinating. And that's what attracted me basically to become a doctor first, and then oncology, more curiosity, more biology, and why the cancer could affect somebody and not somebody else, what could spread, what cannot. But that was probably, the fact that my dad had a cancer was the key for me to develop an interest in medicine.
Yeah, that's really interesting. And you also, you did your training in medicine and your internship and oncology specific training at the University of Turin. And of course, that center's a powerhouse in oncology, led by Dr. Giorgio Scagliati and his international leadership in lung cancer. How much or how little did the strength of lung cancer in that program feed into any focus on thoracic oncology, or did that program really encourage people to develop experience and expertise in several cancers? Because I noticed that your thesis was actually on interleukin 18 and pancreatic cancer.
Yeah. So we need probably to go a bit backwards. So at that time, I think let's say the training was slightly different, and the training program wasn't run yet by Professor Scagliotti. He was, of course, a well-known oncologist, but he wasn't yet the head of of the training program at that time. Nevertheless, the reason why at that time the training I did, it was you had to be exposed to different type of cancer, and then you can develop your own interest. Okay, so I don't know whether it's similar to other country, but basically you have to have a general background as an oncologist, because not all the oncologists in Italy can just focus on one area. There are still general hospital when you have to see all type of patients. So you have to have a general oncological background. Then you can develop your own interest, which is what I did basically. The reason why I also did a thesis on pancreatic cancer was at that time I was very much into, the immunology of the cancer. And there was a very good lab in that hospital with a kind of a good reputation for immunological studies or immunological trials and things like that. So I spent a bit of time working on immunological things like interleukin 18, interleukin binding receptor, and also on dendritic cells. And it was specifically done by a pancreatic team, let's say, people that were dealing with pancreatic cancer. There wasn't much at that time developed for lung cancer. And that was the reason why it was very interesting, extremely, an incredible learning experience. And I learned a lot how to grow dendritic cells, how to do PCR, things like that. Things that, frankly, I vaguely remember now because it's been now 15 years at least. But the way the program was set up was a bit different. You had to be exposed to a bit of everything. And then if you want to have a thesis, you need to find a lab able to help you to have a thesis and become what we call in Italy an MD, which is not PhD, but is kind of becoming a doctorate in oncology with a scientific thesis, which you can publish then.
So after you completed your training, you stayed in Turin, and in that setting, what I could understand from reading your CV is that you were treating a wide range of cancers at that time. I'm interested in what your experience was like with that, whether you enjoyed seeing a broad range or whether at that time, which was, again, a little over a decade ago, it was already becoming challenging to keep up with developments. I think that the field has exploded in the last decade, but I don't know if maybe treating a large range of cancers was a big appeal when you started.
So, no, it wasn't, even when I started. So, again, going back to the way the training was, and also the way the job position were at that time, when I finished my training, I had two options. One option was to develop a career as a researcher, like a scientist, or to continue as a clinician. I couldn't do both. Now, at that time, the problem was, I believe it still is, that if you want to do research, your salary might be quite low and you might struggle. And there were no really appealing position available in Italy at the time, at least not in my area. So the only option I had, which was fine at that time, was to accept a role as a clinician. And in the north of Italy, there's a big hospital. There's really a huge one, but it's more a district hospital. It's not an academic hospital. And there was a new oncology service, which was growing quite quickly, and there was a huge need for oncology. So let's say I in a way, had to accept the job because that was the only job available at the time, which I enjoy. I don't want to say I didn't enjoy because I learned a lot, but as you pointed out, I had to cope with many different cancer. And at that time, there was not even an hematological service. So I went from myeloma to LLC to colon cancer to gastric cancer, and of course I was doing lung cancer. So in a way that clearly helped me. So I was able to treat the vast majority of the cancer, but it clearly wasn't the job of my life. It wasn't something I was prepared to do forever.
So you moved to the UK and specifically to work in Essex. And I'm impressed actually by how many European or perhaps even especially Italian oncologists have been raised and did their studies and then spend their entire careers in one center, often a very good center. But my sense is there is not as much practiced mobility around a country or around Europe or among my European colleagues. And I'm interested in what you were thinking and whether you were really breaking a common pattern by moving from Italy to the UK to work there?
So again, yeah, I think there are not many people that have done exactly that follow my path. It's a bit unique in a way. Some of it was absolutely by chance, and some of it was planned. So while I was working in Turin, as I said, you could certainly perceive it. I wasn't, although it kind of helped me to become the person I am, the oncologist I am today. I wasn't overly happy, and I knew that that was not the job I wanted to do forever. And again, this is my personal experience. I don't want to generalize it, but my experience was that at that time in Italy, what was really putting me off was the fact that I knew exactly what would happen to me in 30 years. So I could predict very easily what the next step of my career would be. And that for me was unbearable. So I needed a bit more of adrenaline. And I always wanted to live abroad. And because I don't know what it is, I've probably tweeted several times, but I don't think I can live in a society where multiculturalism or multilanguages are not embraced. So I love live in society that have multicultural, that have multicultures and multiple language. And at that time, there was a friend of mine working Italian who was working as a consultant in UK, and we were chatting over the phone, and he said, look, UK, you should come over and see. It's slightly different the way it's organized, and I think you would fit very well. How about you come over and just, spend with me a week, a few weeks, or whatever, and then you can gather a feeling and decide. And this is what I did. So I went there, and although it was, of course, for a short time, and you can't, of course, really judge something, but you can have a kind of a feeling, which I had, and I decided, fine, whatever it is, I just want to try. And therefore I quit my job. And it's also it's in Italy, what is also a bit peculiar. And I had what we call a permanent job, which, at that time many people were looking at me like I was completely nuts by quitting a permanent job. And I had my first daughter, she was 1 when I said to my parents and my parent-in-law that we were moving. They were not, of course, very happy at the time. Now they are happier. So, and this adds, bit of peculiarity to the whole story. And I decided to try. I didn't know anything about the hierarchy of the NHS system. I knew that there was consultant, but I didn't know what different there was between a consultant and a registrar rather than a staff grade. And again, at that time, there were not a lot of information available on the internet. So I went there to the Essex, which was in the Broomfield Hospital in Chelmsford, which is a nice city, about 30 minutes far from London, where I did the job as a staff grade. Staff grade is like a senior registrar, but it's not a job that progresses. You can't make you cannot become a consultant by staying there in that role for years. You need to then apply for a different role. But it was good enough for me to understand a bit more the NHS, which is completely different from the Italian system. And they also gained that kind of, I think that kind of security in a way to become a consultant, to take on more responsibilities. So after a few months, I thought I was right. And then I applied for a job as a consultant in Lincoln, which is in the north than Chelmsford. It's about an hour far from Nottingham. And I applied for a consultant job, which I got at the time, and I spent a few years over there. And then it was again a district hospital, and at that time, I moved from the whole family over there again for the second time, and then from there were a few more moves, as you have seen in my CV. But basically, everything started because I knew exactly that I didn't want to have that life in Italy. I wasn't happy. Career-wise, and UK, because a friend of mine invited me over, and what I liked a lot what I saw, and English was the language I studied at school, so it also was quite handy. So at least it's English. I don't have to learn German or French or any other or Spanish, and that's why I went there.
I'd love to know what your impressions were with the move and how you were welcomed, or whether that was a very difficult transition, both for you professionally and personally. And I know you brought your family, and so I'm interested in their perspectives as well, because it sounds like they had, at least your wife's family had some resistance to you leaving. And so what was that like, transforming your life and moving to and living in the UK at that time?
I mean, again, if you ask me, I would say it was amazing, but probably because that's the way I am. But clearly, you have to go through several hurdles. It's obvious. It's first of all, it's all unknown. You go there, you have no idea what the hell you're going through. And you don't know how to open a bank account. You don't know how to rent a house. You don't know exactly how the system works. You don't know anything. And of course, you speak English, although I have to say that the English I spoke at the time wasn't the English I speak now. So there was a bit of a difference, because once you stay in the country, you you realize that even if your language is good on a school level, it might not be good enough to have a normal life or to have a normal conversation. So it was really hard. I think the first probably weeks were really, really, really probably the hardest, I think. As at the time, I remember I didn't have any furniture in the house I rented. It wasn't furnished. So I slept for about 4 weeks on an inflated bed. I didn't have any internet connection. I didn't have even a telly. So I know it sounds silly, but it was tough.
No, that sounds really difficult. I spent a year in the UK, although fortunately, I think I only went about 2 days without television, or these days I can't even imagine living without the internet. I think I would rather go without oxygen than Wi-Fi these days. But at that time, when I was there, that was before people were really doing much. My first experience with email was on green screen monitors back in 1990, 1991. Yeah. That really predated almost any internet experience.
Yeah. So to be fair, now thinking about it, I sometimes wonder how I managed to do it, frankly. But at that time, I was probably motivated. I was so motivated that nothing was going to stop me. That kind of motivation that makes you go through everything without, there were lots of problems, of course. Was I welcome? I think I was, or I felt welcome. Let's put it this way. I felt very welcome. Things then changed. We might talk about it later, because I don't want to talk about politics, but things changed dramatically after Brexit. I mean, at least my perception changed dramatically. But I felt absolutely welcome, and it was a great experience. And the best part was seeing my daughter, and then I also had the second one in UK. Seeing them growing bilingual was amazing. Was really great, and I had the impression things got better over the years, because I got a better job, and then also gave me the impression I was doing the right thing. And so although I was confident, probably too confident, that it would work out, but it did work out. So I was quite happy.
How did your wife feel about all of this? Was she completely supportive or reluctantly so? And did that change over the time you were there?
I think a mixed. I think she was supportive. So she wanted to come over, and she did. But she sometimes she was wondering, why we're here, far from families. You had a job, I had a job. And because we both had what we call permanent job. She's a hospital pharmacist. We both had a job, and we both quit. For the unknown. And this is, again, culturally in Italy, if you tell this story to somebody, they would probably say that we were both crazy, but we did it. So, and it was, I think the worst part for her was every time there was holiday time, of course, there was a chance to get back to Italy, and it was fine. But once it was the time to get back to UK, that was the hardest time for her. And it was the time where she was really wondering whether it was the right thing to do, whether it was, she felt it was a bit unfair, but she's always been very supportive. And if you consider that now we're in Switzerland and she's moved again, yeah, she's been quite supportive. I don't think there are many that would do what she has done.
What was your impression of working in oncology in the NHS system? Was that something that was relatively similar in its strengths and limitations to the Italian system you had worked under, or did you find that the NHS cancer care process had its own greater challenges?
Yes, I think it's very important for me to say that before I moved, I had the personal perception that the NHS cancer care was poor. And I was totally wrong. I think this is also a misperception that we might have given the information we got about NICE not approving something. So this is just the tip of the iceberg. But in reality, the NHS is an amazing public, and I say that it's public health system. And so I've learned a lot from any person who worked in the NHS. And I've come across some of the most incredible consultant oncologists I ever met in my life. The problem, but it was very challenging at the beginning because the system, the way they set up pathways, the way the patient are referred to hospital, of course the care is the same, but the process is completely different to what I was used to in Italy. So it took me a few weeks. It doesn't take you years, but a few weeks to get my head around pathways and primary, secondary care, tertiary care, which all things. What is the role of an audit? What is a clinical governance? What is the NICE? And it took me a few weeks to understand that. Having said that, I think the major problem the NHS has had and still has is, it's not just lack of funding, but it's such a big system that doesn't have enough stuff. It's very simple, and and you can have the best pathway possible because some of the NHS pathways are amazing. But if you don't have enough people, then you can design the best pathway possible. The final outcome will always be not poor, but poorer than what it would be if you had enough stuff. And this is the great limitation. But as an oncologist working within the NHS was absolutely a privilege. And I've learned so much by being there, by staying in UK, that I will always be grateful to the NHS and to you, all my friends in UK.
Most of the UK-based oncologists I know are quite specialized as consultants in lung cancer. I believe you treated several kinds of cancer, but not the same breadth as what you were doing in Italy prior to moving there. Can you talk about what your job entailed in terms of how wide an array of cancers you were treating and what that experience was like?
So basically what happened is, and this was one of the reasons why I wanted to move also. So I was completely convinced that treating all cancer or 4 or 5 different types of cancer was not sustainable. And I don't think it was also good for me, good for the patient. So the first thing I said when I joined Lincoln, it's the Lincolnshire Trust, and when I had this conversation with at the time was the clinical lead, I said, look, I'm happy to join the team, but I want to treat, I don't want to treat 2,000 types of different cancers. My main interest is in lung, and I'm happy to do something else. I'm also happy to help for a while because there was shortage of consultant over there. So I'm happy to cover site temporary because you don't have enough consultant, but it's got to be temporary, and then you need to get somebody else to get these on. And this is what happened. So I was doing lung from the very beginning, which was my main interest, but I was also doing GI because they had upper and lower GI because they had shortage of oncology, but it wasn't my main interest, although it was, fascinating and I learned a lot, but it wasn't the side I wanted to develop more in my career. And then the problem was that in Lincoln, although I was happy after a few years, I definitely wanted to move towards more university academic role. And I had the impression I could do well because I had the impression I could use what I learned even in Italy and writing papers and the research experience I've developed in Italy and also in UK, and perhaps probably be more performant in a way if I could perhaps focus on lung and something else and not just 2 or 3 big cancer sites. Because again, we need to bear in mind that when I was in Lincoln at the time, there were 11 consultants. And when I say 11 consultants, I mean radiation oncologists. But people don't get this. In UK, you have clinical oncologists, and they do radiotherapy and systemic treatment. Okay, so we were. The catchment area was about nearly 1 million. It was 800,000 people, and at the time there were 11 of us between radio oncologists and medical oncologists. So calling this a challenge probably is not correct enough. So the volume, the number of patients I was seeing, it was incredibly high. And again, I wasn't having enough time to develop more research or trials and build up a career. And to be very frank with you, I left Italy because I wanted to build up a certain career. Otherwise, I could have stayed in Italy. And but I understand that in Lincoln was difficult for. Unfortunately, it was difficult to recruit many consultants, and therefore I had to look around. And there was this opportunity in Bristol, where I could do less. I could do lung and melanoma, which was frankly something that really I thought was very appealing. And then I tried and I went for the interview and I got the job. And then we moved again towards the south of England, which is beautiful. Bristol is beautiful. I would strongly suggest everybody to go and visit. It's a beautiful city. And then we spent a bit of time over there in a university hospital, which of course was completely different to what I did before.
What was it like doing a combination primarily of lung cancer and melanoma? I don't know many lung cancer specialists who have a second focus in melanoma. I think a handful, quite a few thoracic oncologists do esophageal or head and neck, and I actually had a secondary interest in GU oncology, which is not a direct connection. I would imagine melanoma isn't particularly overlapping in the general approach or the therapeutics until the last few years, where immunotherapy cuts across all of that. But maybe you can talk about how it was pairing melanoma and lung cancer.
So basically, to be my interest for melanoma started in Lincoln. What happened is that until, as you know, the development of ipilimumab, at least in Lincoln, there was not really a melanoma clinic, because unfortunately most of the patients were treated with some chemotherapy treatment, if any, and the outcome was incredibly poor. Once the melanoma got approved, of course, given the catchment area we had, the volume of the number of patients with melanoma was quite high. Therefore, there was a need for somebody to step in and run a clinic. And at the time, we have some senior dermatologists who had experience, but they also needed an oncologist willing to do so. And I said, look, I think for melanoma, immunotherapy, is going to be the future. I've always been convinced about the importance of immunotherapy or immunology, given the fact that I did also spend years in a lab studying that. So I say, okay, fine, I'm happy to do that. And then by the time goes by, you can see that the immunotherapy became even more important for melanoma. And I would argue that there are few oncologists, not many, few oncologists in the UK that do melanoma and lung, which makes sense because treatment with anti-PD-1 or anti-CTL4 are, of course, now become drugs that we use for both cancer and for lung cancer and melanoma. And also, if you think about tyrosine kinase inhibitor, TKI, we got, BRAF, MET inhibitor. So, those are drugs that are commonly used for melanoma and are becoming more common even for BRAF mutated patient. So I think it was a good combination. I still believe it is a good combination. Of course, there are not necessarily the usual duo you would expect, but I think at that time made sense. And still now I think, treating melanoma is not that far off from lung cancer given the overlapping of drugs we could use.
You alluded to how your perception of how you were treated or welcomed in the UK changed with the mounting campaign for Brexit. Can you talk about that now and whether and how much that contributed to your decision to move to Geneva?
Yeah, it's nothing about, I don't want to make a political statement. It was more what I said the day after the vote. The results of the vote was that for me, I wasn't concerned about the economical impact of this, it was more about the social impact. And I share this feeling with many European colleagues I had, and we all felt, for whatever reason, because probably of the campaign, because again, the campaign was very much about immigration. And in the end, I'm proud of it. I'm an immigrant, and I'm absolutely proud of being an immigrant. But it was so nasty at some point that really, really, I felt that I have to say, perhaps I'm not welcome anymore. Perhaps this is a message to say, man, you're here because we definitely need you. But if we didn't need you, probably we would kick you out. It was just a feeling. It was a perception, but it was horrible. And I remember it was shocking the day. And Bristol, by the way, was a very Remaining city. They voted, I think, 62 or 63% of the voters voted to remain. And when I walked up to the department in Bristol, there were English people, my friends, who were in tears because they kind of sympathize with my feelings, and they felt, even if they vote, of course, to remain, they sympathize completely, and they felt awful for what I was going through. Although, it's not you could do. I understand there are other reasons to go, to absolutely to vote leave. I completely respect that, but the campaign was really, really nasty, and there was a lot about immigration, controlling people coming over, stealing our jobs. So at some point, the perception that perhaps I'm living in a bubble, perhaps I'm thinking I'm welcome, perhaps I'm not that welcome at all. And Brexit was not the reason, was not a reason to leave for me. I think it's absolutely fine for European doctors even to move now to UK or to stay. It's absolutely fine. There's going to be a bit of bureaucracy, paperwork perhaps, but it's fine. But it certainly wasn't a good reason to stay. So when I had this opportunity, the job, they say, knowing that Brexit was going to happen, because that was just the vote, as you can see, it hasn't happened yet, knowing that there was going to be 2 or 3 years of uncertainty and nastiness, and I didn't want to put my children through this, and say, look, fine, I've had an amazing time here. Perhaps this means, and I strongly believe in this sign, probably this means time is over, time to move on. And I did, and I moved to a French-speaking country. So that was a kind of a big move.
Yeah. So tell me about how it was for you and your family. I presume your daughters picked up French. The kids are often more facile with language and cultural changes than adults who may be more entrenched. But so, that's just a few years in now. What's your impression been?
Yeah, the kids didn't have any problem at all. So they now, my eldest, she's 11 and she speaks French, English, and Italian very fluently. I mean, I can't really pick up any accent. The youngest, she's now 6 and she speaks Italian, French very well. She still speaks English, understand it very well, but she has lost it a little bit. In-house, we speak Italian. Although very, very often they watch telly in English because I want them to keep it. And in Geneva, you can speak English with many people. There are many English speakers. For us, particularly for me, because my wife, part of her family comes from France. So she was used to listening to French and speaking a bit of French. So for her, it was a lot easier than for me. I couldn't even count up to 5 before the interview. So I had to study quite a lot before the interview to be able to speak French. And that was a big challenge. But as I say, probably it's a matter of motivation. If you're motivated, you can make it through. So.
And how has your impression been of Geneva? I know it's a beautiful place, not the least expensive place to live, but certainly wonderful if you can afford it.
Geneva as a city is absolutely beautiful. It is exactly the kind of city I have in mind. So when I said multi-language, when I say multicultural, Geneva represents very well this idea. Because here in hospital, I think when I'm walking through the corridor, I could probably hear at least 5, 6, 7 different languages every day. I can speak a few of them, not all of them. I wish I could, not yet. And it's beautiful. It's very well connected with the airport. For us, as I said, we now our families, when I say my family and my wife's family, they live in the north of Italy. So from here, it's about 2 hours and a half, 3 hours by car. Compared to being in UK, that has represented a major step up. So we could see our relatives and our parents more often. Absolutely. Even if we wanted, but I don't want it, even every weekend, which if I don't want it, it's fine. I love them, but I want to have a life. So
no, but that's a good distance. It's close enough that they're accessible anytime.
Yeah. Exactly. And I've it's perfect. So Geneva is a beautiful city, and the lake. So if you ski, it's lovely, and I do ski. My kids have learned. So it's the activity you can do outdoors are amazing. And again, yeah, it's expensive, but I need to point out that everything is, quite proportioned. So salaries are, of course, balanced given the cost of living here. So it's a good balance.
Of course. And I'm honored to be invited to a conference, a relatively new one, the International Lung Cancer Summit that you and Dr. Solange Peters, new president of ESMO, have started. It's happening in mid-May in Geneva. And can you talk about what this format is and what the drive to create a new meeting on lung cancer would be in a setting where there's a lot now of conferences, although also a lot of new content. So what's the mindset of a new summit, and what's that bring to the world that we haven't had?
So yeah, first of all, I'm honored that you accepted to come over. So it's a privilege for us, and I'm lucky enough. And this is something I have to say. So I'm lucky enough to be in Geneva, which is about an hour far from Lausanne, where Professor Solange Vedas works. And for me, it's been an incredible experience to have her on the side. So I'm able to have such an incredible oncologist very close to me, and she's very approachable. So I have to say, sometimes I feel like I'm stalking her because I email her every day questions and things like that. And sometimes I feel a bit sorry for her, but she's so nice. She always reply. And I also have with her, we thought about this conference last year, and it worked out very well, frankly. That's why we decided to try to make it a yearly appointment. The idea is, you're right, there's a lot out. And I don't think I recall we had so many advantages in lung cancer like we had in the last few years. And it's sometimes even difficult, even for lung oncologists, to keep up with all these news, with all the updates. And you go constant results going out, which is great. But sometimes I feel, and that's what the idea we had last year, we don't have the time to digest and discuss all this. We don't want to represent what has been already presented, but perhaps we want to discuss it among, I would say, friends. What is the impact? What is the change in our daily practice? How we can implement what we do, or whether we need to do anything, we need to change it, and try to bring it in a very simple format, if possible, towards as many people as possible. And the idea is, given also as you said, so many conferences, we cannot travel all the time. It's impossible. And there's also brought in the other idea, which was to broadcast the conference for free. And again, I want to say this because it's important. So everybody could join us, could register for free. We got the website, I think is already open, which is lungcancersummit.org. When people can register for free, they can follow us, or it's going to be recorded. It's going to stay on the website for a few months. So people who could not watch it live, they could watch it, I don't know, a week later, or you can even watch it over the days if they don't have enough time to watch 8 hours, which I understand. So the idea was, to have a more, I would say, informal format where we're not just presenting data, which are absolutely interesting, but in the end, there are questions, there are problems. Perhaps we want to discuss the data more thoroughly. And the second things we really wanted was to make sure that all the information were available easily to everybody for free. Which, believe me, it's quite difficult, but we managed very well last year, and we're going to manage again very well this year, hopefully. And I hope it's going to be well attended, by people from Geneva, but also it's going to be very well followed by people online, which I think it's what we are willing to get.
Well, I can tell you that Geneva in May was a draw for me. My wife was very supportive of coming along, so I hope listeners will decide that it's worth coming. And I do see the appeal of a conference that's really focused on commentary and clinical significance in the setting of all this sea of new data, but trying to digest it and what it means in a setting that is relatively informal, I think is a very welcome format.
Yeah, well, hopefully it's going to be a success.
I'd like to close with your thoughts on the various healthcare systems that you've experienced or know about. You have now worked in 3 different countries with different healthcare systems. You're heavily involved with ESMO as well. And I also imagine that just based on what you've heard in various meetings and Twitter conversations, you're somewhat familiar with Canadian healthcare, US-based healthcare, and probably some of Asian healthcare systems. Is there any system that you see clicking on all cylinders that's working as well as you could hope or close to that? Or with all of your experience in the various healthcare systems for cancer care, do you think that we still need to have a system that takes some of what's good in the US, maybe the availability, and other things that are much better about healthcare in the UK or Switzerland in terms of the access broadly across a population. What are your thoughts about what an ideal cancer care system in a broader healthcare program look like?
Yeah, there's a difficult one. I think, of course, the problem, it's very complicated to give you a straight answer. I think any different health system has some limits and some great stuff. So this is for the Italian system, for the UK NHS system, and for the Swiss one. The problem is that also the system, in a way, is also based on the culture of the people who live there. So there are things that you could do in UK because people have a certain culture. They used to have a certain system, and things you can do in Switzerland because people are used to a certain way of having an health system. So I don't think you can dramatically change one or the other. There are a law, and then also the first question you need to ask yourself is whether you want a public health system or whether you want a private health system, because this is what is the first question you need to ask yourself. And if I have to be honest with you, of course, as a patient, I can see why I would prefer to be treated in Geneva because it's fast. They react very quickly. You got access to basically all the possible medication available. You might even go off label. But in the NHS, you don't have that. But on the other hand, in the NHS, whatever is done, it's done. It's a public system where everything is done on the evidence-based medicine and all the, I don't know whether you have had the chance, but if not, you should. All the nice appraisal about drugs are fantastic manuscript. They are like incredibly written, which they analyze the data really thoroughly. So, but clearly as a patient, sometimes they don't perceive the problem of the economical or financial impact. Therefore, patients say, okay, whether the osimertinib, just to come up with an example, I have an EGFR mutation, I want to have osimertinib, then you can have it in Switzerland, and you unfortunately cannot have it in UK at the moment. It is not because of nice fault, but it is probably because it's very expensive. But as a person, as a patient, I don't think you can perceive or appreciate really the financial impact on the society. Well, UK is sort of the best drug. So I don't think there's any health system better than another. And I strongly believe, and again, that might be a bit of a political statement, that the only way to get a better health system would be to have a kind of European agreement on not the way we run the system, but the way the drugs are priced. Because this is what can make a difference for oncological patient, at least, okay? For others, I don't know, but for oncology patient, the difference is having access to a drug or not, depending on the price. This is the reality. And in Switzerland, patient can have access to all the new drugs, which doesn't mean necessarily it's better, but I understand the patient point of view that wants to have access to the drug as soon as possible. And on the other hand, I understand the UK to say, okay, but it's not affordable. The price is crazy. If we accept that, we will have to cut on, I don't know, other services, and we cannot afford that. So I think any system has its pros and cons. As a patient, if I have to choose at the moment, I would rather want to be treated where I am at the moment because I could have access to drug, but I'm not confident or sure that the way the system is set up here will be sustainable over the years if the drug prices continue to go up.
And it's interesting that the US system doesn't bubble up as one that's really worth envying. There is the opportunity, if you have the means, to do a lot. There's certainly a good bit of latitude, but there's so much disparity based on the extent of resources you have and the insurance coverage that it's very humbling knowing that the cost of healthcare is so great and the outcomes are so modest for the resources spent on it. So it's really telling, and we struggle mightily when you talk about the sustainability in Geneva, but the costs are not as great as the healthcare costs in the US. And of course, we are deeply pained about questions of sustainability when the cost of cancer drugs is now routinely eclipsing $10,000 or $15,000 a month.
But also the other point about the health system in Switzerland, it's very equal. So even if it's set up different from the NHS, everybody completely, irrespective of the type of insurance they have access to everything. There's no limitation. And that is, for me, that is absolutely a must.
No, that's wonderful. Well, it's great talking to you. Of course, I look forward to seeing you in person and enjoying the culture, the beauty, all of the experience of being in Geneva with you and being part of the International Lung Cancer Summit. I hope people who might be thinking of it could find a way there. We'd love to have rich live conversations and broadcast it all over the world. In the meantime, thank you, Alfredo, for taking the time. It's great talking with you.
Well, it's been a real pleasure, frankly, and I'm really looking forward to seeing you here and to, of course, have a bit of time to chat and perhaps to eat together the fondue, which we tasted last year with Stephen and the guys.
Yes, well, I'm afraid of that. I'm going to take double my atorvastatin that day.
God, you have, yeah, but we got to go through this, so we got to do it.
Okay. Well, you take care. Bye-bye.
And you, take care. Bye.
Thanks for listening. The West Wind Podcast is a Beacon Medical Interchange production with sound engineering and distribution by Mark Lindsay of Talking Speaker. We hope you'll be motivated to subscribe, whether at beaconmedic.com, through iTunes, or through another podcast service. Please also rate it, and I hope you'll be inclined to tell friends and colleagues in real life and on social media. We're always happy to get your suggestions and other input at westwindpodcast@gmail.com. Talk to you again soon.